Hey guys, it's about, I don't know, 11:30 Monday night, and I'm trying to get this up for you guys. Sorry, I've been busy with my haunted house. I did not get to the computer until late tonight, but I did send out an email to everybody. I can't figure out what's going on with ATI. I have everything open on my end, and it's open for me when I went into my student portal, but everybody's still having troubles getting in. So I'm going to call ATI in the morning and try and get it fixed, and then I will figure out a due date. I know right now it's due on the 12th, but I will give you guys time to get it done. So, alright, this is the normal postpartum adaptation, and then to the nursing assessment. It is a longer PowerPoint, but a lot of it is actually, if you look at it closely, it is a lot of repetition. And I wanted to go over this one first before I went over the abnormal, so you know what to expect and then what's different than the norm. It always takes me a while to get off the first slide, and I'm not really sure why. There we go. So, postpartum period is called the fourth trimester, and it's also called the puerperium. Basically, that's from the birth of the baby till 6 weeks after the baby is born. So, physical adaptations in the reproductive system, there are quite a few. And if you kind of think common sense things, you'll get through this a lot easier than if you try to memorize. So, involution. This is when the uterus actually goes back to the size it was before the mom was pregnant. It's about the size of a pear, and then continues to shrink down actually. On the left here is a uterus that's contracted and in the right size, and on the left hand side is the regular uterus, and on the right hand side is actually one that still has placental fragments or something in there that's causing it not to be able to contract. And so you can see it's a lot bigger and it's not firm. So what affects this uterus to getting back to the normal size? The involution of the uterus. If a labor is long, sometimes anesthesia will really slow down the process. If there is, like I said, placental fragments, if the placenta still, pieces of the placenta are still in there, if mom has an infection, if there are twins in there, you know, multiple birth, if it's a large baby, if there's extra fluid in there, anytime where that uterus is stretched out to its max, it really has a harder time shrinking back into that pear size. A full bladder actually can keep that uterus from contracting and getting into the right size, or a difficult or long labor birth where there's lots of trauma. So, fundus, if you guys have ever heard this word, it is the top portion of the uterus. Some of you maybe have been able to feel mom's fundus on clinical already, but it feels kind of like a grapefruit. If you can find it, sometimes it's deep, sometimes it's right on top. Sometimes you'll have to search and sometimes you won't. So once that baby's born and the uterus continues to contract, the placenta comes out. And even after that, the uterus continues to contract, so that all the blood vessels are basically tied off, clamped off, so that after that baby's born, you can imagine that uterus, that fundus part, is actually drops way down when the baby's first born, immediately. And then right after that, it raises back up. So within, I don't know, half hour, that fundus should be right back up to the belly button. I know on this slide it says 6 to 12 hours, and I did find that in the book somewhere, but just know that immediately it drops down, but within minutes it's back up to that belly button. It should be firm when you palpate it. If you've ever heard a nurse say that the uterus is boggy instead of firm, this is actually called uterine atony. So when they feel for the fundus, it's soft, it's spongy. Basically, it feels like a wet sponge. So the first thing they're going to do is really massage that uterus. And for you guys who have had babies, this is not so fun. If that uterus is boggy, mom's going to have more of a risk of postpartum hemorrhage because the fundus can't contract, it can't compress, and it can't clamp off those blood vessels. So here's a picture. As you see, fundal height at delivery basically is right at the belly button. If you go in to check mom and you see on this picture here, this mom has a full bladder. Generally that fundus is not going to be midline. You're not going to find it right at the belly button. It's going to be deviated off to the right. So if you do ever find that, the first thing to do is have mom urinate, then lay back down and assess the fundus again. But a lot of times this is what the problem is. Lochia. This is basically the debris that the uterus is expelling. It's almost kind of like their period because it's the shedding of the inner lining of the uterus. It changes from day to day of what type of lochia the moms will see. This is one big thing that we need to educate them on. So for about the first 3 days after that baby's born, they're going to see a dark red. This is called lochia rubra. And if you know, I think sounds like a Spanish word to me. I'm trying to find ways to help you guys remember. So from about the 3rd day to about the 10th day, so about a week, they're going to have what's called lochia serosa. And you can you can see, well, there's rosa in there. That's how I remember the thing, or the progression of it. And that just means it's pink. It's serous. And then the 3rd stage of it is lochia alba. This just means white. A week and a half, 2 weeks after that baby's born, for a week or 2, and then it's going to stop. So remember, lochia rubra is the first one, and that's red. Lochia serosa is the 2nd stage, and that's pink. And lochia alba is the 3rd stage, and that's white. Lochia should not have an offensive odor. If you teach mom that anytime they have an odor to their lochia, they need to really be looked at for an infection. If after about 4 days, the lochia should be turning pink, and especially if it turns pink and then turns back to bright red, have that mom notify the doctor immediately. They are more than likely, either there's something extremely wrong or they are overdoing their chores, their tasks. But they still need to notify that doctor. So not only do we need to teach mom the progression of the type of lochia, but we also need to teach her, and we need to know ourselves for our charting, how much lochia is regular, how much to chart. So if there is about a 1-inch stain, just a very small area on a pad, that's a scant amount. And when I say that there's a 1-inch stain, this is within an hour time frame. So the best thing to do, what I do is I have mom go into the bathroom, change her pad, clean herself, and then in an hour I come back and check. So I can just kind of gauge where, where a starting point to where I'm actually assessing the amount of lochia. So if there's a 1-inch stain, maybe the size of a quarter on that pad, we consider this scant. Light can be up to about 4 inches, a 4-inch stain on her pad. Moderate is about half of the pad. If half the pad is soaked, then I would consider that moderate. If that whole pad is soaked within an hour or less, this is heavy, and this is really not normal at all. This is grounds for hemorrhage. So if you have a mom that's soaking a pad in an hour or less, we really need to be looking at and see if her fundus is boggy or firm, and to see what's going on with mom. Cervical changes, I don't expect you to know a whole lot other than this. If you think about it, the cervix is going to be flabby and shapeless immediately after birth. It was just basically went through trauma. And that's kind of what it looks like. Kind of looks like something that belongs in my haunted house. Vaginal changes, that's kind of the same thing too. The vagina also went through trauma, and it's stretched, and sometimes it rips, and so it might be swollen, it might be bruised. The rugae will return to the vagina within 3 to 4 weeks. And the mom who is not breastfeeding or non-lactating moms, it might be back to normal in about 6 weeks. The breastfeeding mom, the mucosa is going to be more pale, and there's not going to be any rugae because their estrogen level's lower. And it may also be dry because of that low estrogen level. Perineum is swollen and bruised as well. Lacerations and episiotomies can actually take up to 6 months to heal. You can kind of see where the perineum would be bruised, swollen. If you look here, you can see the location of the episiotomy. Oh, sorry. And they either go straight down, which is midline, or off to the side. So, classifications of lacerations. There's a 1st degree, a 2nd degree, 3rd degree, and a 4th degree. 1st degree is just a little tiny tear. All the way up into a 4th degree is from the perineum, vagina, all the way up to the rectal muscle. Basically, from one end to the other. So menstruation is different in all moms. In about 70% of all the non-breastfeeding moms, it may come back by 7 weeks, in about 70%. Generally, menstruation is returned in 12 weeks to all non-breastfeeding moms. Depending on how long the mom breastfeeds, they may not have their period for up to 3 years. It just all depends. Maybe they exclusively breastfeed for the 1st year and either pump or breastfeed here and there up until baby's 3. They do not get their period while they're breastfeeding. And ovulation it's basically related to how long the mom nurses. Like I said before, if they're breastfeeding, they're not going to get their menses back. If they stop breastfeeding or they're not breastfeeding exclusively and using some bottle feeding, sometimes it will come back. But just know that it depends on how long mom's breastfeeding. Alright. The belly. Generally it's loose and flabby. Yeah, the return to normal kind of depends on how mom's doing physically, how many babies she's had, and how much exercise she does. Oh, the diastasis recti abdominis. I can't say that word. I apologize. So this first picture is a normal belly without any problems. The middle picture is a picture of a pregnant mommy where those abdominal muscles have stretched and separated. And then the last picture is basically mom after she has the baby. So you can see even after she has the baby, these muscles don't go right back to each other. And you can about imagine the hole that she's left with. So kind of depends on another. I mean, this is the same kind of thing we talked about the belly. Otherwise, how many pregnancies have they had? How big was their space in between? How much exercise are they doing? And what's their general normal condition? So, and just plain exercise isn't going to get rid of a diastasis recti. Um, there are special exercises that mom would have to do. Striae, we're all familiar with those. Those are basically another word for stretch marks. And in the GI system, they're bowels. Bowels are usually slow and sluggish after the baby's born. There's a lot of different things that happen, that occur. Either it's the muscle tone isn't as strong because of all the trauma, and hate to tell you guys who have not been in the labor and delivery room, but mom does poop once in a while. So a lot of these moms, bowel movements are going to be scary after they've had a baby. They may kind of try and put it off and not want to, but it's just going to be worse when they do. So if we can just teach moms that it's a good thing to go when they have to go the first time, it's a lot easier. And having moms take stool softeners, whether they're a vaginal birth or a C-section, is generally a good idea. It just makes that stool a lot easier to pass for them. Urinary tract. Mom is at risk for overdistension, residual urine, and the inability to empty her bladder completely. That bladder is bigger, but they might also have a lot of swelling and bruising of their urethra from when the baby's head came down. And they may not have all their sensation back, so we just need to remind them, especially one who's had an epidural or anesthesia. They may not feel that they have to go to the bathroom. And then bladder tone usually comes back within a week. Oxytocin, everybody's favorite question on the exam. Oxytocin continues even after the placenta's delivered. The moms actually get a shot of IM oxytocin just to kind of keep that uterus to keep it continuing to contract. But when they get that, it actually has a little bit of a diuretic effect. So mom might have to pee a little bit more. But not only does oxytocin give that diuretic effect, but remember mom has about 40 to 50% more blood circulating to help circulate with baby. Well, she's got to get rid of that. So after the baby's born, they might actually notice an increase in the urinary output just because mom's trying to get rid of that. It might be up to 2,000 to 3,000 extra mLs. So just give mom a heads up that she's going to be urinating even more than normal. Moms are at risk for UTIs. Again, it's just common sense. There was trauma to the urethra, or they're retaining urine because they don't have any feeling. So we just need to keep an eye out for mom for any signs and symptoms of infection: fever, chills, difficulty urinating, burning, lower back or flank pain. So if you think about it, not only did the urethra and all of that have trauma to it, but when mom was getting checked, she had hands up in there. So just keep a close eye for mom. And even the C-section moms, they're going to have a catheter, and that's another huge risk for an infection. So, vital signs. So we'll start with temperature. Mom's temperature might increase for a little bit. after baby's born, just because they're dehydrated, depending on how long their labor was and how long they were pushing for, and kind of all these things come into play. But they're dehydrated, they're exhausted, and it might cause their temperature to go up. So anytime you see an increase in temperature, even though it's normal for their temperature to go up, within their milk coming in, or to be dehydrated and exhausted, if you have a temperature increase, always, always, always check for an infection somewhere. Blood pressure, it's going to increase during labor just because the adrenaline's going, and they're in pain. So, but it'll return to normal. Always watch them close, especially in a C-section and a tubal ligation, because there's surgical procedure. Decreased blood pressure is actually a very late sign of a hemorrhage, and so that's why it's very important for us to be checking lochia. And I'll kind of go through it at the end of these slides of how to actually check for it. But this is one thing that we need to make sure that we are watching the amount for, because by the time their blood pressure drops, they're pretty far into a hemorrhage. Yeah, even after birth, they are still at risk for preeclampsia. So if the blood pressure's up, that's one thing to worry about. It doesn't happen very often, but it can still happen. Or if there's too much use of oxytocin to, what's the word? Induce labor, or vasopressors, so their blood pressure would be up. Their pulse, it's called puerperal bradycardia. During the first week or two, that pulses might actually be bradycardic. Their blood volume's lower, their cardiac output is lower, their cardiac effort is lower, their stroke volume is lower. But anyways, it's because they're getting rid of all that extra fluid. They're going to about half of the blood they're used to. If we do notice that they've got tachycardia, either they're dehydrated or they have an infection, they're in fear or they're in pain. So just kind of keep an eye out. Think about those things. Generally, it's normal for that to be a little bit lower, but if it is higher, make sure you're checking for dehydration, any type of infection, and check and see if they're in pain. Maybe they need a pain pill and then it'll go back down, or maybe they're nervous about something. Sorry guys, I'm tired. Cardiovascular. So their cardiac output is going to decrease 30-40% within the first 2 weeks. They're going to see a diuresis during the first 5 days. So I told you there's a lot of repetition in these slides. Moms might actually see a weight loss just of that for about 3 kilograms or 6-7 pounds. If mom isn't complaining of this diuresis, that fluid is still, in the extracellular spaces, so mom can still be at risk for pulmonary edema. So we really need to instruct her to let us know if she doesn't feel like she's urinating enough, or getting kind of annoyed at urinating too much, just because they are at high risk for other issues. Their blood actually gets more concentrated, so the hemoglobin and the hematocrit actually look higher than they really are. So mom's breast. Um, the alveola, actually, their growth is regulated by their estrogen, their progesterone, the lactogen, the prolactin, the cortisol, and insulin. Um, Basically, the lactation, once it's the starting of it, the estrogen is actually decreasing, and so is the progesterone. But the body is excreting prolactin now, and that's actually going to start the lactation process. When baby starts sucking at the breast, the mom's body actually releases oxytocin, which causes the uterus to contract, which then stimulates mom to release milk. So it's all kind of tied together, even when baby's not in there. So moms that are going to be breastfeeding, in the first day or two, baby might be a lot more cranky or extremely cranky because they're not, full like a formula-fed baby. But for the first day or two, mom's going to have colostrum, and it's not a whole lot. It's a very, very small amount. But it's a thin yellow fluid. It's got more protein, contains a lot of immunobodies, helps with their immune system. And like I said, it's a very small amount. For the first 2 weeks, that milk's going to be a transitional milk going from this colostrum. And milk supply is going to start increasing. The more the baby feeds, the more the body will produce milk. So starting about the 3rd week, mom's actually going to notice a change in her milk again, and it's going to be the mature milk that comes in, and then that's the milk that the body will continue to produce till she's done breastfeeding. So moms that are not breastfeeding and using formula, their colostrum is going to come within the first 24 hours, and within the first 3, 4, 5 days, their breasts are going to be completely engorged. Their body's actually starting to produce the milk because they still have all those hormone changes. They're just not having the baby suck at the breast to release that oxytocin. So within a week, the engorgement should subside. But moms are going to have to do a few things to. Oh, I guess it's not here. It's farther in. Mom's going to have a few things to do to help that engorgement subside and to have the milk production stop. Hormonal changes, like I said, it's kind of different for non-lactating and lactating women. We kind of went over this, the estrogen and the progesterone return, which causes the menses to return in the non-lactating, the non-breastfeeding women. In the moms that are breastfeeding, the progesterone will actually drop and stimulate the prolactin, which in turn stimulates the breastfeeding of the milk. Ovulation can actually occur within 2 weeks to a month after weaning that baby. Then they're going to, when they ovulate, is when they can get pregnant. So they don't get their first period for 2 weeks after they ovulate. So just remember to teach mom that breastfeeding is not a for sure means of birth control. Weight loss. I hate this picture. That was never to me. I did not return to pre-pregnant weight within 2 months. Absolutely not. And I don't know that I've ever looked that good in a tight little black dress like that. So basically, mom's going to have 10 to 12 pound weight loss from just the birth of the baby. It may be more, but it is quite a bit, depending on how big the baby is. They're going to lose another 5 pounds from that diuresis. So that's right there, 17, 20 pounds that they may lose within, a couple hours, couple days. Postpartum chill. Mom is going to get extreme shivers after birth, kind of like she's freezing to death. But there are a few different causes, what they figure. Um, there's a sudden release of pressure on those pelvic nerves. There's the baby to mom transfusion. Mom might be producing more epinephrine, and sometimes they link it to an epidural anesthesia. This is normal in the new mom. I kind of tell them, it's kind of like you had an adrenaline rush. Now your body's trying to catch back up. But if they are having a fever, we always need to check for an infection. Postpartum diaphoresis. Mom's body is going to be trying to get rid of all that extra fluid. So they may have increased perspiration, especially at night. They may put their call light on in the middle of the night and say, my pajamas are wet, my bed's wet. And all we can do is say, yeah, that's pretty normal, and change their bed sheets and get them clean pajamas. After pains. This lasts for, I think, maybe up to a few more days than 2 to 3. Depending on if mom's breastfeeding. If mom's breastfeeding, it's going to occur a little bit longer. But when that uterus is actually stretched way out, mom is going to really feel it a lot more when that uterus is trying to get to that pre-pregnancy site or size. Whether it's, like I said before, whether it's twins, triplets, there's a lot of fluid like a polyhydramnios, or a large baby. Yeah, we kind of talked about this. So the treatment for after pains, you can have mom lay on her belly when she's getting them. Use a warm water bottle, a warm blanket, or even take some Tylenol before she starts nursing. So, the postpartum psychological adaptations, I guess, is what this section can be termed as. So, taking in phase. This is immediately after baby is born. Generally, mom's passive and dependent. Her biggest concern is her needs. She needs to eat and she needs to sleep, especially if she's had a long labor and long delivery. Food and sleep are going to be her priority. She's going to need to tell you all about, especially if you were there during labor and delivery, she's going to want to talk to you about it. If you were not there, she's going to want to tell you about it. So once mom has rested and ate, she's going to be more concerned about the baby. If she's breastfeeding, if there's, newborn, the newborn cares, changing the diaper, keeping baby warm. She may be more confident in being a mom, but she's still going to have those mood swings, and this is the taking hold period. Maternal role attainment, also called becoming a mother or BAM. This is the process in which mom learns how to be a mom and actually identifies herself as a mom. It all kind of progresses. Goes from birth till about 10 months after that baby's born. So you're going to notice the beginning portion of this, the maternal role attainment or becoming a mother. You're going to see the beginning stages of this while they're in the hospital. So kind of help mom out with this. Let's get into the stages of it. It'll make a lot more sense. So, anticipatory stage. During pregnancy, she's going to be looking at other moms out there and just kind of saying, what should I do as a mom? How should I act as a mom? Um, so then, when the baby's born, mom will enter the formal stage. She's going to be very influenced by others. She is going to basically act how others would expect her to act. This is where, the mother-in-law is coming in and saying, well, I never did that with my son. So she's going to pick up that behavior. Then she goes into the informal stage. She's starting to make her own choices, but she's still following and acting how others want her to act. She's working on finding ways that work well for her, but she's still trying to figure out a balance of, my mother-in-law thinks I need to do this, but I want to do it this way. So she's kind of trying to figure out what works better for her. And so the last stage, the final stage, is called the personal stage. This is where mom is comfortable with herself as a mom. She's taking recommendations or tips from everybody else, but she's comfortable with how she's taking care of her baby. So does that make a little bit more sense how you're going to see the beginning of while they're in the hospital? And then if you do work in a clinic, you might see these other stages unfold, as you would say. So postpartum blues happens to everybody. It's just this short period, first few days up to the first, 10 days or so, where mom is depressed and sad, but she still has, happy times where she's still bonding with that baby. But she's going to have mood swings. She might be angry. She might be tearful. She might have problems sleeping, and she may not really want to eat. Especially in a first-time mom, they're nervous about everything. And it kind of, and their hormones are all shifting, so this is pretty normal for most people. A few days of this waxing and waning emotions. If it hasn't resolved in 2 weeks, then it kind of goes into a postpartum depression, and it needs to be something that that mom talks to a provider about. So this is one thing that we teach them. Yes, it's pretty normal to have baby blues for a little bit, but if it goes on to 2 weeks of feeling down, or you're just really not feeling like you're bonding with the baby, or you've been crying more and you can't stop, then you need to talk to a provider. It can get so bad as the postpartum psychosis, where they might be psychotic, they might be hallucinating, they might be or they might have delusions, and this is something that needs to be treated right away. So when we see mom, whether we are at the hospital or at a clinic visit with mom, we really need to assess her emotional status. We need to assess her attitude. And I have on here, does she want this baby or not? Well, it sounds kind of I don't want to say a stupid question, but it sounds like, well, but I've been in rooms where the baby was there and mom was more concerned with being on her phone. The nurse was taking care of the baby and mom was texting somebody on. And I'm not saying it was, just, oh, hold on, let me finish texting. But she really didn't pay attention to what that nurse was doing. So, mom might be concerned about other things, and maybe she's just not bonding, so it doesn't appear like she wants the baby. We need to assess her feelings of competence, whether it's a new baby or maybe mom's just feeling overwhelmed. If she's a first-time mom, and maybe she's a single mom, and this is just all new to her. We need to assess if they're fatigued. Maybe they've had a 42-hour labor and a traumatic birth, maybe they're just extremely worn out. Maybe they've been up taking care of the newborn the whole time for the past 24 hours, round the clock. And like I said, it might be a single mom. But maybe they might be just fatigued. Maybe they just need the nurse to take the baby for a little bit, tell them to take a rest, and they'll feel a little bit better. But when moms are fatigued and exhausted, this is actually one of the top 4 reasons that they actually enter into the postpartum depression. So we need to really watch and see if they're fatigued or overwhelmed. Another part that we need to assess in their emotional status assessment, what do they have for support? She's going to get a lot of attention while she's pregnant, but once she has that baby is going to get 99.9% of the attention. Babies are cute, babies are tiny, everybody loves a baby. So let's see what she's got available for her. Does she have family? Does she have, her mom around, or maybe a sister, or anybody of her extended family? Maybe she's really close with her cousin, and her cousin's able to help out. Does she have a husband, a boyfriend, a girlfriend, a wife? Who is there for her after she has this baby? Maybe she just relies on friends, or maybe she just relies on a church group. But we need to kind of figure out what she's got available and kind of really talk them up because they're going to need support. All right. Physical assessment. So once mom has her baby, these are not set in stone, and they kind of depend on the facility. So once mom has her baby, a vaginal delivery, assessments are going to be done every 30 minutes for 2 hours, every 4 hours for 24, and then every 12 until they're discharged. A C-section delivery, that's the same as a surgery in most places, but in the book it tells us every 30 minutes for 3 hours, every 4 hours for 48, and every 8 hours until they're discharged. Now, I don't expect you to memorize each time frame. I just wanted you guys to see this to get kind of an idea of how often to do assessments. If you're working in postpartum, you're going to have basically the own policy to the facility, but this is just kind of gives you an idea. Vital signs. One big thing, when you are about to do a physical assessment, make sure mom's not in pain. Maybe she needs a pain pill before you go in and give her privacy. As when the nurse does a postpartum assessment, they're not going to want all of her visitors in there. So we can ask them to step out, because sometimes mom isn't in a place to feel okay about having her visitors step out. I had one young mom. She was 17. She had just had twins. The babies were in the NICU. They were born very early. I want to say probably 30 weeks maybe. One of the babies wasn't doing well. But anyways, while she was in labor with these babies, her friends were sitting in the room, chatting with the doctor, playing on their phones, laughing, giggling. And mom was too timid to ask them to leave. She felt bad. So then, after the twins were born, her friends kept calling, her family kept calling and saying, "Oh, we want to see the babies, we want to hold the babies." Well, they're in the NICU for one. Generally, for the first 24 hours, nobody's allowed to see those babies except for mom and dad. And after that, it is just immediate family only. So she was having a hard time, and she was telling me, "Oh no, my friends want to come see the babies." And I said, "You know what? Blame it on us. They're not ready to have visitors, and neither are you." And she's like, "I can do that?" And I was, "Absolutely. You can even tell them my name. My nurse Lisa says that I can't have visitors yet, and neither can the girls." So kind of make sure that we're helping her ask visitors to step out. Have mom go to the bathroom before, just so that you're not feeling for the fundus and it's not deviated to the right. So just have her void before the assessment. Rubella, it's usually done while mom's pregnant. They can get the vaccine, but it is a live attenuated virus. If they are not immune, they're going to need a titer. And those are some pretty common. It's with any other vaccine. Rogam shots. Another one that everybody loved. Mom is Rh negative and baby is Rh positive. So if dad is Rh positive and mom is Rh negative, this is where you're going to have problems. Because if dad is Rh positive, baby's going to be Rh positive. If mom is Rh negative, that's where the issue lies. So this Rogam shot is given at 28 weeks to prevent mom from developing antibodies that are going to attack the baby, and then it is given again after delivery. It's given every time after an Rh positive baby. The signs take when they're resting, same with the baby. Temperatures, elevated temperatures should only last 24 hours at most, but anytime the temperature is elevated, we need to be watching for infection. Blood pressure, it's going to be rise during labor and delivery and immediately after birth, but it'll be stable other than that. Remember, the pulse is going to be, they might be bradycardic. Normal is 50 to 80, but remember that anything over 100, we're going to be looking for dehydration and hemorrhaging. Lungs should be clear, but we need to make sure that we are monitoring the C-section and the preeclampsia mom, just because they're a higher risk for pulmonary edema. Breasts, need to assess them for size, shape, abnormal areas, if it's red, hot, engorged. So we want to see them, we want to be able to chart that they're slightly firm. That just means they're filling with milk. Really hoping that they are not extremely firm, they're not engorged, they're not warm, they're not tender. That runs into a lot of other problems. Their nipples should be free from cracks, inversion, sores, fissures. But until mom's nipples get used to baby sucking at the breast, they're going to be very sensitive. And these cracks, these fissures, can actually happen quite easily if they're not careful. Maybe if baby latches on wrong just once, they can cause a fissure, a crack, or a sore. We kind of went over this. First 2 days, it should be soft. Third day, it should be filling, so it should be slightly firm. Third to fourth day, they're going to be larger. They might be taunt, shiny, can be hard, tense, painful, just because they're so full. But if there's only one area that's red, we need to watch for mastitis or plugged duct. In the belly, the fundus, we kind of went over this. Have mom void before she goes, or before we do our assessment. We don't want that uterus displaced to the right. Plus, we don't, if the bladder's full, their uterus is not going to contract and they're still going to be bleeding. Always look at the C-section incision for healing and for infection. Things we're going to look at is if the wound edges are approximated, if there's, moderate to heavy bleeding, if there's any other drainage, if there's a foul odor coming from that, or if it's red. We just don't want any infection in there. Fundus, again, we're going to look and see where, if it's firm or boggy, where the height's at, and if it's what position it's in. Is it left? Is it right? Is it centered? You can measure how many finger breaths that fundus is at the belly button. It might be -1 finger breath or +1 finger breath. If the fundus is midline but higher than expected, think about that there might be actually blood clots hanging out in that uterus, preventing it from tightening up. Fundal massage, we want to help mom make sure that she's not bleeding, or if we look at her pad and determine that she's got quite a lot of bleeding since the last time we checked, we're going to want to do some fundal massage. So we're going to find the symphysis pubis. Is basically, we're going to put our hand just above that, and then the other hand we're going to take and put on the top portion of the uterus, the fundus, and kind of feel for it. If it's kind of soft, we're going to want to really rub on that area. We can teach mom, we can teach mom how to rub her stomach 4 to 5 times a day to help with any bleeding. Make sure mom knows signs and symptoms of infection. There are hands up and up there, and lots of issues going on. Teach her how to wash her hands appropriately, and then teach her how to really clean the perineum. Wash from front to back, and change her pad after every time she goes to the bathroom. No tampons, because that kind of sits in that area and might actually cause more infection. And use that peri bottle to rinse. So, lochia, we already talked about a lot of this. We're going to be wanting to look at the amount of lochia, if there's any odor, if there's any clot. Make sure mom is avoiding changing the perineal pad, and then we're going to look at the lochia in an hour. Remember that if we determine that mom is saturating a pad within an hour or less, this is considered very heavy bleeding. So we need to assess her very closely and consider that uterus is not shrinking down. There might be fragments of that placenta still in there, or if that's not the case, then there might be a laceration. So kind of check it out and see if it's more the uterus or if there's other issues that might be causing it. Lochia, like I said before, there should not be an odor to it. If there is, then there's more than likely an infection there. And C-section moms may have less lochia. That's just because that came out through the surgical area when the surgeon took the baby out. So when we are assessing mom, it's not a bad idea to have her lay on her side on the Sims position like you see in the picture. Just because that's going to show us everything we need to see. If the mom has had an episiotomy, which is not very common anymore, I guess, we need to use the term Rita to remind us everything to look forward or look at and assess. If it's red, is there edema? Is there a large amount of bruising? Is there any discharge from the area? And are the edges well approximated? When they're laying like that, we can also assess and see if she has any hemorrhoids. If she does, we're just kind of note the amount, the size, if they're painful, tender. We can always use this time to teach mom about some pain relief measures or signs and symptoms of infection of that episiotomy site, or kind of discuss the healing process with her, or anytime any constipation measures that she needs to do. And I know students are really kind of surprised on how easy it is to teach. Um, what are you doing? Oh, I'm just checking your backside to see if you have any hemorrhoids. Sometimes moms get hemorrhoids while they're pushing, so we just kind of keep an eye out. Sometimes they get it from being constipated. After they have the baby, they go home and they're constipated. So, maybe taking a bowel softener twice a day will help with that, and it'll keep you from getting, hemorrhoids, or it'll keep you from hurting so much when you have your first bowel movement. So as you see, you can kind of turn everything that you're looking at down there into something you need to teach mom. I'm just looking at your episiotomy scar. That's going to start healing together. It's going to start itching. But if you have any, feel like it's red, or you feel like there's a different type of drainage, or if there's an odor, maybe you should have it looked at, because those are kind of some of the signs of infection. Or teaching about pain relief. Oh, if your backside is sore, why don't you try sitting on an ice pack for 20 minutes, or doing what's called a sitz bath, or sitting in the bathtub. So you can kind of turn that all around, and really use the time when you're doing your assessment to teach mom about all this stuff. We're going to look for any DVTs, especially in the C-section mom. Assess the pedal pulse. Make sure their home sign is all over the place in these books and these slides, but please do not do a home sign anymore. That's kind of why I left it in there. If you are doing a home sign where you're pulling the toes up towards the kneecap and you bust loose a clot, yeah. So I really recommend not to do the home sign. Just kind of go by the look. It's going to be red. It's going to be hot. It's going to be bigger than the other side. If you see that, have them checked out. It's not worth risking dislodging that clot. We want to make sure mom's up and walking early to kind of prevent some of these, and always making sure that we're feeling for the pedal pulse. Just because if there's a clot, you're not going to feel that pedal pulse. We can basically, to prevent a clot, we want mom up walking as quick as possible. We're going to have her wear TEDs and not AEDs, SCDs. I don't know why it says AEDs. Must have been my 2 o'clock slide that I made. So it's the sequential compression devices. Treatment, if they do have a blood clot, we want them to rest, elevate that leg, start activity gradually progressing, and they're going to be ordered heparin, whether it's Lovenox and Coumadin, or one of those other newfangled blood thinners, which any of my students in my clinical can attest to how much I dislike them, just because there's no way to monitor them and there's no antidote. So if you have to have a blood thinner, just go with good old Coumadin. But they might go home on like Lovenox or something like that too. Elimination, help mom go to the bathroom as soon as possible after birth. Help her to the toilet. Sometimes running water or pouring warm water over her vulva actually helps her urinate. And remember, catheterization is always a last resort to everything. We can get mom to urinate on their own, woohoo, the better. Yeah, we kind of know all of these. If bladder's distended, that uterus is going to be boggy. Like I talked about before, bowel movements might actually scare some of these moms. So we want to tell them that, here, this is what you should take, a stool softener, so that it's not as painful when you do go for the first time. Rest and sleep. We should really encourage our moms to take a nap when that baby's napping. I don't know how often Gunderson takes babies other than to like do the assessment into the nursery, but when I was doing OB, if generally we did labor and delivery and postpartum. It wasn't just one or the other. So maybe one night we'd deliver with mom, and then the next night we'd come and we'd take care of mom and baby. So if mom was very tired after a long labor, a long delivery, we would just take babe into the nursery for a while and let mom take a nap. So it's good to encourage this just because, like I said, she may not feel up to asking her visitors to leave, so she may really want someone to step in and say, "All right, guys, I'm gonna send everybody home so she can take a nap. It's nap time here in the unit." Nutritional status. There's not a whole lot here. Mom's weight might take up to 6 months. Encourage fluid intake. Encourage fluids high in fiber to help with that constipation. Mom may be anemic after childbirth. So, moms that are not breastfeeding, we need to reduce their calories by 300 daily. Now, so they are at their pre-pregnancy amount of calories. So, recommendations for healthy weight loss, 1 to 2 pounds per week. The breastfeeding moms, so when they're pregnant, they need to eat 300 above their normal. And now that they're breastfeeding, we need to increase that yet again by 200 for a total of 500 calories over their pre-pregnancy requirements. For the moms that are breastfeeding, we need to make sure that they've got a higher protein and a higher calcium intake. I'm not going to go through all these. You guys can look at the normal findings. So if you're trying to figure out a way to remember the assessment points on a postpartum examination, you can use the the mnemonic bubble HE, and that way you'll get breast, uterus, bubble, bladder, lochia, episiotomy, hemorrhoids, and emotional status. So that way you are hitting all of those important parts to assess. You can also use what's the bubble leb, but basically it is not much difference. H for hemorrhoids, H is here for Homans. So we just know that we don't do the Homan sign anymore. So perineal discomfort. What can we teach mom? We can teach mom to use that peri bottle. Change that pad with each void. Wash from front to back. Wash hands. Basically, we're going to try and get them to do anything they can do to prevent any infection. Ice can actually be applied on 20 minutes, off 10, on 20 minutes, off 10 for the first 2 hours. And that ice can actually be kind of a numbing, so it feels very nice to mom. Sitz bath might be ordered. Basically, it can be ice or hot or cold. I couldn't even talk. Kind of reduces that edema. You can use topical agents. I don't know how often facilities are providing some of these things. Tucks are amazing, and they just line them up on their pad and kind of a cooling type feature. Dermaplast, I recommend this to any mom going into labor, any future mom, just because it's kind of a numbing spray, so it helps when they're going to the bathroom, it helps if they're having pain. It's kind of just a nice nice thing to help recommend for moms. Hemorrhoids, you can look through here and see what the treatments for hemorrhoids, but hemorrhoids do occur with childbirth. After pains, we talked about this, more commonly felt by, there's twins, triplets, or more, whether there's a lot of fluid in there, when you've had more than a couple babies, and breastfeeding moms. They're all going to feel the after pains. So moms can lay on their belly, they can walk, they can take some Tylenol before they breastfeed baby, and maybe try a warm blanket on there. Postpartum diaphoresis, there's really nothing we can do for them for it, other than make sure they've got, dry pajamas, dry bed linens. If they're really feeling a hot flash, maybe they want to take a cold shower, and just encourage fluids so they don't get dehydrated. So if mom is using formula, so in order to suppress the lactation, if mom is not going to be breastfeeding, we need to teach her to we need to teach her how to suppress that milk production. So if they wear a 36C bra, we're going to encourage them to wear a 34B bra. So down one size so that it's conforming and tight. And especially a sports bra, that will help it a lot more. We're gonna teach them to put ice packs in their armpit areas for at least 20 minutes, at least 4 times a day. And they are going to teach them to avoid warmth, heat, and any type of stimulation for about a week. And by stimulation, I'm talking by their partner. Mom's resumption of activity. Basically, we're going to teach mom to avoid any heavy lifting, any strenuous activity for at least 2 weeks. We're going to encourage her to take naps when the baby naps, and encourage them to return at 6 weeks or later. So if mom is experiencing lochia alba and she's been trying to clean her house for the past, 4 or 5 hours, sometimes their lochia is going to turn back to that bright red bleeding, or it's going to be a lot more. Mom is just doing way too much. Simple exercises are okay right after birth, whether they're kind of walking around. They might start their Kegel exercises, but remember, increased lochia and increased pain they're doing too much. Sexual activity, moms resume sexual activity once their lochia has stopped and their episiotomy is healed. But teach moms and dads that mom's estrogen levels might be low, so the vagina might be dry. So they can use like a KY jelly or a water-soluble lubricant. Instruct moms and their partners that if mom is breastfeeding, they should know that they might experience leaking or squirting during intercourse. Like I talked about before, and I'm not going to go into big detail, ovulation happens about 2 weeks before the menses starts, so don't use this as a form of birth control. Discharge teaching. So mom's return appointment is going to be about 4 to 5 weeks, maybe even 6. They can shower or bathe as needed. Mom's driving should be limited for the first 2 weeks. The return to work or school. Docs will generally start allowing this 6 weeks after baby's born. But these are the moms that might actually have the higher risk of exhaustion, which leads to the postpartum depression. So just kind of tell mom be careful about going back too early. Teach mom that she shouldn't lift anything heavier than the baby. Sexual activity, like I just said, when their perineum is healed and mom feels comfortable and that episiotomy is healed. Housework, teach mom to limit it or ask for assistance. No douching, no tampons. Anytime, these are called danger signs. So we need to make sure that we are teaching mom when to call a provider. So anytime that her temperature's above 100 degrees Fahrenheit, maybe her breasts are hard, red, painful, and warm, or maybe even her lower extremities are the same thing, hard, red, painful, or warm. So we need to monitor for a DVT. Call provider if she's got any foul-smelling discharge. Call provider if she's got heavy bleeding, if she's soaking a pad within an hour. Maybe she's got extreme sadness after a week and a half, 2 weeks. And always tell mom, call your doctor if you just don't feel right. They are generally the ones that have a gut instinct that something is wrong. So always listen to your moms when they say they just don't feel right. I think that is the end. It is. Alright, guys. I'm going to record the other one in the morning, but I wanted to get this one out there for you guys who wanted to start on it. I know it's kind of long, and how long did I take? Oh my, it was over an hour long. Alright, well, enjoy this one, and I will record abnormal signs of, or abnormal complications of delivery in the morning. Have a good one, guys.